So our last module is going to be going over eating disorders and autism spectrum disorder. This last one's very quick, just 24 slides. There's not a whole lot of treatment options for these outside of psychotherapy, but there are some medications that have efficacy. It's all medications that you've seen before, um, except for maybe one or two the eating disorder medications, but it's mostly use of other, either antipsychotics or SSRIs that we've seen before. So we might as well jump into it. Our first eating disorder is anorexia, where the treatment guidelines are to restore weight gradually, 2 to 3 weeks if you're 2 to 3 pounds a week if you're inpatient, and a half a pound to 1 pound a week outpatient, because we want to monitor the patient closely, make sure they're not gaining too much. Want them to gain the right weight, along with psychotherapy, understanding that it is okay for them to gain the weight back appropriately. You definitely want family-based psychotherapy. It has the greatest efficacy in adolescents and young adults. You may want to do adjunctive pharmacotherapy, but the best case would be to avoid it until the weight is restored. And you may need to do, you would not want to do hormone replacement therapy for patients, even if they've become, if they have developed amenorrhea or something like that. We would, it'll normalize as they gain the weight. So pharmacotherapy treatment concerns are that the reason we have those is because malnourished patients are sensitive to anticholinergic and cardiovascular adverse effects. So we want to avoid those. Caffeine and exercise should be avoided to prevent arrhythmias. And electrolyte abnormalities can increase the seizure risk if we do those in combination with medications in combination with anorexia. And changes in fat and protein may alter drug pharmacokinetics. So the guidelines, all the guidelines have psychotherapy as a first line, but if you're going to add in medications, the APA say SSRIs only in combination with psychotherapy for persistent depressive, anxious, or OCD symptoms. Again, this is after we've gained the weight back, and to maintain natural weight and a normal weight, and to decrease these symptoms that may cause a relapse. Second generation antipsychotics may be useful in patients with severe unremitting resistance to gaining weight, useful for severe obsessional thinking and denial that assumes delusional proportions. The NICE guidelines never recommend medications as a primary treatment. The WFSBP talks about patients with comorbid conditions that may benefit from it, using olanzapine, quetiapine, and zinc supplementation to help gain weight and help with mood, and metoclopramide to help accelerate gastric emptying. And the Australian guidelines say that there's weak evidence for psychotropic medications. So the main point is it's always psychotherapy and possibly medication. So our options, for medical issues, malnutrition, we're going to want to give a daily multivitamin and zinc supplementation, which you can see is controversial, but we may need to give that to our patients because they are, nutrient depleted. Constipation, you prefer to stay away from stimulant laxatives. Do something a little more natural. Flaxseed, bulk forming laxatives, which are fiber based, or stool softeners, which just take the water that we naturally intake and puts it into the stool to make it easier to push out. If we have abdominal bloating and pain, you can give metoclopramide, but you want to avoid long-term use. For amenorrhea, we're not going to treat the amenorrhea. The menstrual cycle will resume as weight becomes normal. And osteopenia, if it's present, we're going to treat with calcium and vitamin D supplementation like we would for a patient with osteoporosis. So adjunctive psychiatric pharmacotherapy, your main one is going to be antidepressants, SSRIs first line, after weight restoration, because fluoxetine, which is one of the ones that has been studied, showed no benefit in underweight patients. So you're going to want to get them back to normal weight and then use the SSRI to control or to improve the depression and their obsessive compulsive symptoms. TCA should be avoided due to arrhythmia risk and overdose risk, and bupropion should not be used because of seizure risk. Also, bupropion decreases your appetite, so you're going to want to avoid that. That's another reason to avoid it. Antipsychotics, mixed evidence. There's, but you can use, quetiapine and some of the other ones for, symptom control. It may also help with the weight gain in those patients. For bulimia, nutritional guidelines, again, nutritional rehab and psychotherapy, always first line. Treatment with SSRI, fluoxetine has been studied as an effective adjunctive treatment, specifically focused on reducing binge purge episodes. And it's usually used in higher doses than used for depression. Bupropion is contraindicated due to seizure risk, and we are going to avoid TCAs, lithium, and MAOIs due to safety and tolerability. Medical treatment would be the same as we listed above. SSRIs are efficacious in decreasing the binge purge behavior, anxiety symptoms, obsessions, impulsivity, and depressive symptoms. Fluoxetine, citalopram, and sertraline have all been studied. They are higher doses than usual, and those high doses can decrease the binge purge episodes, regardless of co-occurring depression and anxiety. Fluoxetine is the only one that is FDA approved, but again, we mentioned earlier that the other two have been studied and shown to be effective. And you can see that the goal dose is 60 milligrams a day, when usually the goal for depression is 40 milligrams a day for fluoxetine. Again, I say usually because I have seen occasionally patients above. I've seen 60, 80 milligrams for depression, but usually 40 is the goal, 20 or 40, and then but for bulimia, where the goal is 60 milligrams a day with a likely onset in 2 to 4 weeks, so slightly earlier than depression symptoms. And Topamax, just for completeness, has been shown to have short-term efficacy, but I don't think there's any more evidence than beyond that little bit of short-term efficacy. Treatment guidelines are going to be nutritional counseling and psychotherapy, which have the greatest efficacy. Topiramide, zonisamide, or an SSRI should be considered adjunctive only. And I'm sorry, this is binge eating disorder. We skipped, and I didn't even see the title change. Nutritional counseling, psychotherapy, and then those three can be considered adjunctive. Lisdexamfetamine, usually used for ADHD, was recently received FDA approval for binge eating disorder. The results of a multinational phase 3 study found that for patients with moderate to severe binge eating disorder, continued treatment with lisdexamfetamine reduced the risk of relapse over 6 months compared to placebo. And you can see this. The link down here will go into more detail, but the lisdexamfetamine seems to be very effective for binge eating disorder. Other agents, orlistat has shown some research and efficacy. With that, you're kind of going to get your antabuse or disulfiram reaction like you do with alcohol. They eat it, they feel terrible, they have nausea, vomiting, flu-like symptoms. Well, with orlistat, when you eat fat, it makes your body get rid of the fat. So to the point that they tell you if you're taking it for dietary reasons to lose weight, you may want to carry a second set of pants with you wherever you go. So it has that. It's a negative feedback reaction. Acamprosate and naltrexone have not been shown to be effective monotherapies, and you can use anti-obesity agents. But the negative is the side effects you have. So like phentermine, which can cause weight loss if the patient has it, but the risk of heart valve deformation and pulmonary hypertension has to be considered. Phentermine plus topiramate or the other combinations can cause weight loss, but they don't have data in binge eating disorder. And lorcaserin was approved from the market. Or was approved but then removed from the market, so it was used for weight management, but was used off-label for a binge eating disorder, but is no longer an option. The reason that is, I'm sorry, that title looks terrible right there. The reason it was removed from the market is that so it's based on recently completed analysis of the data from the Camellia TIMI 61 trial, where the manufacturer decided to pull it from the market because it was there's an increased risk of cancer. So you can see with the data, it was pulled from a post-marketing study looking at 12,000 patients. Cancer risk was 7.7% in study population, 7.1 in the placebo, and the cancer types seen more often were pancreatic, colorectal, and lung cancer. And it seemed that the cancer cases increased the longer the duration, the cancer risk increased the longer the duration was. So based on that, the medication was pulled completely from the market. So will there be future medications for this disorder? I think there could be. Desatralene, which is being looked at right now as it's a dopamine norepinephrine reuptake inhibitor. It's come out and had some positive and some negative results for, I think, positive for binge eating disorder, negative for ADHD. But you'll hear it mentioned a little bit more because they're doing phase 2 trials to try to find a good disease state for it to hit the market with. But there's the results right there for that. So autism spectrum disorder. So treatment guidelines are obviously not pharmacology related. So it is early intensive sustained interventions and family support, getting baseline information, behavioral interventions, and then you get to medications that they do not cure or manage the core symptoms, but can help manage associated symptoms and comorbid diagnoses. So you may use it when social or daily functional impairment exists. Doses should start low and be titrated slowly because patients on the autism spectrum respond to lower doses of medication than the normal population. And there's definitely a greater reduction in symptoms when you use combination versus medication alone. When you want to use it with behavioral management. Obviously, there are a lot of non-pharmacologic treatment options, which all should be used. You can see the list here, but they're very effective. We can use pharmacologic agents for treatment of symptoms. So, disruptive behaviors. There are 2 second-generation antipsychotics that are effective: aripiprazole and risperidone. That are FDA approved for the management of irritability and aggression. And they are considered first-line agents. So you can see they can be used as early as 5 or 6 years old, and they reduce aggression, temper tantrums, and self-injury. Behaviors may reappear when the medication is discontinued, so we know that they're working. And like with the risperidone, you can see here the max is 3 milligrams a day regardless of the patient's weight, and you want to start at 0.25 milligrams and go up, or 5 milligrams if they're over 20 kilograms. So you can see it's a low starting dose, and then going up to a max of 3, which is not even half of what our normal maximum is. And with aripiprazole, starting dose of 2 milligrams daily, and then going up to a maximum of 15. If you are going to go with aripiprazole and you're going to titrate them up, instead of doing a prescription from 2 milligrams, which is very hard to find, even though it's generic now, it might be harder to find. You may want to do a 5 milligram prescription and then tell them to take half of it. Then they can go from 2.5 to 5 and just go to a full tablet. That might be easier for the patient to get a prescription of. There are first generation antipsychotics that can be used for disruptive behavior. They're not FDA approved. That is basically because companies aren't going to pay for this approval now. These drugs have been out for too long. Something we've talked about before. Just because it's not FDA approved doesn't mean it's not effective. We just don't have the phase 3 double-blind studies to show it. So haloperidol reduces social isolation and stereotypies, and may also improve anger-related behaviors. Again, low dose and up to 4 milligrams daily. This 4 milligram daily dose is nothing compared to what we use in our patients with schizophrenia. So you can again see how low the dose is. Chlorpromazine and fluphenazine have efficacy but are limited by their adverse effects. Mood stabilizers have inconsistent results to reduce irritability and aggression. It is a good treatment option if they also have comorbid seizure disorders. So you can use Depakote and go for a goal of 75 to 90 micrograms per milliliter. Lamictal and Keppra have no significant effect on irritability, and possibly some other with benefit. Hopefully we'll get even more data on these is the N-acetylcysteine, memantine, and amantadine. So for repetitive behaviors and stereotypies, SSRIs, they're not FDA approved, but you can see they have fluoxetine has a marginal decrease, citalopram had no decrease, and the thought is that serotonin activation may cause increased activity, mood changes, and insomnia. So maybe it's useful, or maybe it's not. Antipsychotics, there's no FDA approval for these behaviors, but it appears that Haldol does help with these. The second generation antipsychotics, risperidone has the best efficacy, and aripiprazole has some also if you need to switch to it due to tolerability, and Depakote reduces those behaviors also. ADHD symptoms, stimulants are good. ADHD symptoms in patients with autism. Stimulants are better for hyperactive and impulsive symptoms than for inattentive symptoms. Adverse effects, you can see they're dose-related. Compared to normal peers, lower doses are needed, and there's higher incidence of adverse effects and lower response rates, but they are an option. And atomoxetine is used for hyperactive and impulsive symptoms if stimulants fail. So again, the Strattera, atomoxetine is a second-line option for patients on the autism spectrum. Also, natural products, polyunsaturated fatty acids may be used in adjunctively to the other treatment options. Could be helpful. Probiotics may be helpful, and zinc supplementation possibly may improve cognitive function, but I'd like to see more studies before recommending it for a lot of patients. There is a medication that just got through phase 2 trials. It's probably in phase 3 right now. It has been about 2 years since this came out, but it's called L1-79, so it'll get another name soon. But it's a new drug that can mitigate socialization and communication symptoms in patients with autism. So it's actually given fast track designation to try to speed it up to the market. Its mechanism of action is a tyrosine hydroxylase inhibitor believed to modulate the catecholaminergic pathways involved in autism spectrum disorder. The phase 2 study was a very small sample size, but it showed reductions in irritability, lethargy, hyperactivity, and anxiety within days of initiation. It also showed improvements in speech, communication, socialization, and awareness of self and others. So if this continues down the path of development, we may have a great class of medications that could really help patients on both ends of the autism spectrum. Or on the entire spectrum, this could really help all of the patients. So keep an eye out for more of that coming out. Hopefully soon. That's it for this module. There's not a lot medication-wise. If you have any questions, let me know.